The content herein is for informational purposes only, not intended as medical advice, diagnosis, or treatment, and is not to be substituted for direct advice from your doctor.
Welcome to Lymphcast, the gathering place for physicians, healthcare experts, and special guests. We dive into the world of lymphedema, venous disease, and other related disorders, exploring their impact on your daily life. So settle in, unwind, and join us as we uncover everything you need to know about lymphedema and related conditions on our engaging show Lymphcast.
Today's Lymphcast program is proudly sponsored by VitaSupport MD, the makers of Vein Formula 1000 and Lymphatic Formula 1000. These MPFF-based nutraceuticals are backed by science and recommended by doctors specializing in venous and lymphatic disorders. Visit VitaSupportMD.com to learn more.
Greetings and welcome to our Lymphcast show, episode 35. Just a reminder, all episodes are on YouTube. You can also find us on any podcast platform out there, including Google Podcasts, Apple Podcasts, Spotify, and so on down the line. And we are glad that you are with us today, again, for episode 35. Let's go ahead and meet our panel, and then we will get right into meeting our guest and have a great hour of discussion. From Arizona, Dr. Monica Glavitsky. Hello, Dr. Glavitsky. How are you?
Hello, everybody. Good to be with you again. And, I'm looking forward to this exciting episode.
All right. Great to have you with us. From California, Dr. Emily Eicher. Hello, Dr. Eicher. How are you?
Hi, team. Hello, everybody. And I can't believe this is already the 35th podcast. So we are happy to be here.
All right. Thank you for being here as well. From New York, RVT, Jacqueline Sasek. Hello, Jacqueline. How are you today?
Oh, happy to be here. Thank you.
All right. Thank you. And from New Jersey, the gentleman who started this entire show, he's also the founder, owner of VitaSupport MD. They make Vein Formula 1000, Lymphatic Formula 1000. Physician, surgeon, Dr. John A. Chubak. Hello, Dr. Chubak. How are you, sir?
Hi, Paul. I'm doing fine. Thank you very much. Looking forward to tonight's program.
All right, great to get ourselves going here. And Dr. Chubak, I'll kick it right back to you if you'd like to bring in our special guest tonight.
Of course. It is my distinct pleasure to introduce today a dear colleague and dear friend for many years, Dr. Barry Franklin. I want to give a little bit of background because our history together is very, very interesting in many ways. Barry and I have known each other, I would say, well over 10 years. And we came to know each other initially through a very interesting process. Many years ago, when I opened my vein-based practice, one of the things that I was noticing was a large number of overweight and obese patients. And I was contacted at that time by a very interesting company called the Center for Medical Weight Loss. And Jackie was working with me at that time in the office. And I was very interested in what they had to offer. They were a company which still is in existence, the owner of which, Richie Lee, I'm still quite close with, and Kevin Eberly, who was working as their president and CEO. They approached me about opening a weight loss program in my practice, which we did, and we ran very successfully for years. As a result of that, over the years, I began speaking for the company and talking about entrepreneurship in medicine and private practice. And at several of the conferences, I had the incredibly good fortune to meet Dr. Barry Franklin, tonight's guest. And whereas I was speaking in those days about entrepreneurship in medical practice, Dr. Franklin was speaking about all of his areas of expertise in terms of obesity, heart disease, coronary artery disease, cardiac rehabilitation, et cetera. And that's how we first came to know each other. And later, we came to find that we both had a great interest in personal development and success training and so forth. And Barry has written a great book, which I have with me, right, always by my desk. And as a matter of fact, that's not a staged plug. It's always here with me. And we're going to talk about that tonight. And so it was just ironic that over the years, we both wrote books on personal development and success training and so forth. And we remained fast friends. And I want to tell everyone a little bit about Dr. Franklin's background. Like you, Paul, he is familiar with the Detroit area. He has his Bachelor's of Science in Health and Physical Education from Kent State University. And after attending Kent State, where Barry was also, I should mention, an accomplished male gymnast, competing for the gymnastics team there. And he went on to get his Master's in Science, his MS in Health and Physical Education at the University of Michigan, which of course is another renowned institution of learning. And finally, he went on to get his doctorate in physiology at the Penn State University, another fantastic university. And it seems Barry would have been exposed to some great opportunities to see some amazing football too over the years. I should say that his career then spans several decades, almost 4 decades, and some of his titles include Professor of Physiology at Wayne State University School of Medicine for the last 28 years, almost 29 years, Professor of Internal Medicine and at Oakland University William Beaumont School of Medicine in Rochester Hills, Michigan. And he's also the Director of Preventive Cardiology and Cardiac Rehabilitation at Beaumont Health for the last 38 years, almost 39 years. And again, as I mentioned, for the last 23 years, he's been doing some motivational speaking and writing, which has become a great passion of his, as it is one of mine. And he's received many, many accolades, many awards. He has either authored or co-authored 700 scientific and clinical publications, including 26 books, dating all the way back to 1976, although he still looks like a very young man, and he's as fit as a fiddle. He's given over 1,000 invited presentations nationally and internationally, and just as a matter of fact, has returned from a teaching position in South Korea. So I could go on and on, but we only have an hour. Dr. Barry Franklin, my dear friend, welcome to the program.
John, thank you so much for the kind introduction. It reminds me of a comment my wife recently made, who oftentimes sits in these podcasts or is in a talk that I'm involved in. And she said, I figured out something about you after 52 years of marriage. And I said, what's that? She said, I think you'd like to hear yourself introduced before you do all these things. Anyway, I get no respect at home. That's why I'm here tonight.
Well, it's wonderful to have you. I want to jump right into our questions. And I suppose I'll go first because you have so much to share. And we have so many listeners who are eager to learn so much of what you have to share. So the first question would be, and this is something I learned from Barry many years ago, and I find extremely important. Can you talk to us about metabolic equivalence, also known as METs, and how this metric is used clinically in prescribing exercise and in exercise testing?
John, thank you. It's a fundamental question. It's a question I address almost at least once a week. When we talk about metabolic equivalence, John, it's the amount of oxygen consumed at rest. So if I put a mask on you and measured your oxygen consumption right now, on average, it would be 3.5 ml per kg per minute. So if we take a patient and we've got him or her on the treadmill and we're measuring oxygen consumption and we get 14 ml per kg per minute, that tells me he or she is working at 4 METs. 14 divided by 3.5 is 4, or 4 times resting energy expenditure. We can measure METs directly, or we can estimate METs based on the attained speed and grade on a treadmill. You mentioned exercise prescription. Fortunately, guys like me have a compendium we can look at, and you name any activity, and I can tell you the approximate energy cost. For example, walking at 2 miles an hour is 2 METs. Walking at 3 miles an hour is 3 METs. If you say to me, I want to play singles tennis, that requires about 6 to 7 METs on average. Or if you're into jogging or running at 6 miles an hour, that's 10 METs. How do clinicians like you and I use that? We do a stress test on somebody, and we look at the peak METs that they achieved on the stress test. And if a patient has a 5 MET capacity, And he says to me, Dr. Franklin, I want to go back and play in singles tennis. I used to play a lot of singles tennis. Would I recommend that? No, I wouldn't recommend it because singles tennis requires 6-7 Mets. He's got a 5 Met capacity after a heart attack right now. So we use that to gauge the safety and appropriateness of physical activity. Lastly, when we do a stress test, and a lot of docs don't realize it, there's magical information in that stress test beyond the EKG, beyond ST depression, beyond arrhythmias. And based on the speed and grade, we can determine a person's cardiorespiratory fitness or aerobic fitness. That's the highest METs they achieve on a graded exercise test. The higher the METs, the lower the mortality. And oftentimes I highlight the fact that each 1 MET increase in fitness corresponds to about a 15 to 20% reduction in mortality. And I tell our fellows and residents, that's similar to the mortality you get when you prescribe aspirin, statins, beta blockers, or ACE inhibitors after acute myocardial infarction. So METs can be very much used for exercise prescription and during exercise testing. Those are the keys.
Can you say that again? I think that's so important, that statistic that you just mentioned. I think that's powerful.
Well, the final one is each MET increase in exercise capacity or fitness transforms to about a 15 to 20% reduction in mortality. And that compares very favorably with the statins, aspirin, beta blockers, ACE inhibitors that doctors commonly prescribe after a heart attack. I'm not saying throw the aspirin, statins, beta blockers out. What I'm saying is tell your patient, get physically active, improve their fitness, and you're going to get some independent and additive benefits as a result.
Fantastic information. Good. Does anybody on our panel have another question for Dr. Franklin?
We have plenty of questions.
Great.
I have a question. So you worked with this evaluations mainly for the cardiovascular diseases, so mainly on the cardiac and arterial side. Is that any implication of this METs in varicose veins, lymphedema, lipedema, how it fits to this kind of pathologies?
I've been studying this particular topic since my hair was black. So as I look at your particular question, I think it's important to recognize that regular moderate to vigorous physical activity or an improvement in the exercise capacity has therapeutic benefits for virtually every medical condition. So I'm talking about obesity, diabetes, hypertension, chronic kidney disease, atrial fibrillation, incident dementia, cancer, atherosclerotic cardiovascular disease. So although there aren't a ton of studies looking at patients with lipedema, I'm convinced that more physical activity, higher levels of fitness will guarantee greater survival in that particular patient population. I can also say that a number of studies suggest the value of physical therapy in that population to reduce pain, to improve functionality in persons with lipedema. Abnormal tissue sodium accumulation in the legs, which was typically established as a biomarker for that condition, was decreased following a study in which they used physical therapy visits in patients with lipedema. So to get to your question, in a nutshell, more physical activity, higher levels of cardiorespiratory fitness expressed as METs or ml per kg per minute, no doubt can have a profound impact on the quantity and quality of life.
So should we recommend the stress test with the MET evaluation for those patients?
This is something I'm very interested in, and actually as a follow-up to our discussion this evening was going to discuss with Dr. Chubek to see if in fact he would be interested. I believe that this patient population relative to this aspect has probably been understudied. And if we get a sufficient number of patients and follow them, not only in terms of functionality, but quality of life, associated risk factors, long-term survival, this is a paper we probably could publish in JAMA, New England Journal of Medicine, or possibly Lancet. I'm a big fan of getting things in Lancet. So
let's do it.
So anyway, those are my thoughts regarding that particular question.
Who's next? Emily, do you have something?
Yes, for lipedema, because I see a lot of lipedema patients. And I sent, John, I don't know if you received it, I sent lipedema stage 1, lipedema stage 2 and 3. Those are women with adipose tissue disorder, and it involves a lower body enlargement in symmetrical distribution of lower extremity enlargement with cutoff point at the ankles. When it goes beyond physiological problems, then they may turn into lymphedema, where the feet are also involved. Usually in typical lipedema, we don't have involvement of feet and toes. Now, these women tend to have great difficulty with ambulation, with light jogging, because there is excess of a volume, adipose tissue volume, around the knee joint, and later on it progresses maybe distally. Depends what kind of a stage they are and what kind of a type they are. They have very difficult time with exercises. And going back to my rehab, I do remember that mopping the floor was 7 mats. So every night when I do some cleaning up the house, I do 7 mats cleaning the floor. So what type of exercises do you recommend for these women when they have joint problem?
The question is an excellent one. For many of our patients with orthopedic musculoskeletal problems, we have a pool actually in our facility, and we've used water aerobics, which minimizes orthopedic or musculoskeletal stress or trauma. We also have, in contrast to many gymnasiums, probably 20 different pieces of exercise equipment, because I came to the sobering realization everybody's not going to walk on a treadmill. Everybody's not going to necessarily pedal a stationary cycle ergometer. So we've got arm ergometers, we've got combined arm-leg ergometers, and I'm convinced that despite the orthopedic and musculoskeletal limitations, we can find equipment that would enable these women to exercise at 2 or even 3 METs. The magical number, based on my experience, and we can talk about this later, is we want to get patients out of what we call the bottom 20%. This is the least fit, the least active, those at highest risk. And lots of studies suggest if we can get them exercising, not mopping at 7 METs, but if we can get them exercising at just 3 METs, which is not that difficult, we get them out of that bottom 20%, there's a huge decrease in mortality, a big increase in survival overall. Also, people have oftentimes underestimated the amount of exercise that you actually need. I was one of them. I originally said to patients, you've got to do 60 minutes or 40 minutes. Many of my patients with heart failure or morbid obesity can't do those kinds of activities. What we've come to the sobering realization is that the effects of exercise are cumulative. So, for example, for a heart patient I have who says, Dr. Franklin, I can't walk for 15, 20 minutes. My answer is, can you do 3, 4, 5 minutes? Oh, yeah, I can do 3, 4, 5 minutes. If that's repeated throughout the day, the effects of exercise are cumulative, and relative to weight reduction programs, we have good evidence today that 3 10-minute bouts are more effective than 1 30-minute bout because metabolism remains elevated for a period of time. So to address your question, I'm absolutely convinced that we could modify the exercises appropriately to make people successful, to allow them to accomplish, despite orthopedic and musculoskeletal problems, small bouts of exercise repeated throughout the day. As a side note, we play volleyball in our cardiac rehab class with middle-aged and older patients with heart disease, some in heart failure, and we allow 1 bounce of the ball per side. Whoever invented volleyball would turn over in their grave if they saw how we play volleyball, because we can make people who are uncoordinated, unfit, instant success. So the key is modifying activities to make it pleasurable, to eliminate the pain or discomfort, and to make it enjoyable. And I'm confident that with the lipedema patient population, we can do that.
This is absolutely fantastic information, and I want to say that I could see Dr. Eicher smiling a bit, because the first place you went with it, Barry, is her absolute wheelhouse when you mentioned swimming. She's recommending swimming for these patients all the time. And whenever I speak to her about one of my patients, difficult, challenging case here on the East Coast, she's always telling me from the West Coast, do whatever you have to do to get them in the pool, right, Emily?
Absolutely. The question was, today I had a patient and she said, yes, I am in a swimming pool. However, and she is lipedema stage 2+. So quite involvement of lower body, disproportionately disfigured with the upper body, where the upper body is much smaller. But she goes to a swimming pool, which is for rheumatoid arthritis. And she said the water is so hot, which is so difficult for lipedema patients that they are already large and now they are in. So I suggested to go to some YMCA where the temperature of the water is around 80, 85 instead of 95. And would you agree, Dr. Franklin?
I think that's a reasonable alternative. We have a pool here. It's usually warmer, but our cardiac patients still use it for periodic exercise and so on and so forth. But I agree, we've got to adapt the exercise modality, the program, to make it fun, enjoyable, and therapeutic. And we've done that. I've done that my entire career with patients with coronary artery disease, by using different devices, by using different protocols, and by using what I call intermittent training. Instead of 20, 30 minutes, which is unrealistic for a lot of people, short bouts of exercise repeated over time can be priceless. I tell our patients, the analogy I give if I'm sitting with you, Emily, is you don't have to put the dollar bill in the piggy bank all at one time. You can put 4 quarters, you can put 10 dimes, and if you got heart failure, you may have to put in 20 nickels or 4 and 5 minute bouts of exercise, but all that accumulates. I do a lot of writing. And you say, Barry, what's your secret? I do a page here, I do a table here, I do another page here, and pretty soon, as John can testify to, you got a book. And so
great book, fantastic.
Small bits over time accumulated can have a big impact.
Yeah, I did it the same way with my writing. Barry, I want to get to one question before I forget it, because in all of the things that you ever taught me, as a cardiac surgeon, this, I think, is the most profound in many ways. Talk to our audience and our panelists, please, about how important exercise is for those people who are completely or nearly sedentary, as opposed to adding exercise to people who are already quite active and physically fit in terms of the health benefits. I think you know what I'm referring to here.
Yeah. The individual, John, who gets the most benefit out of an exercise training program is the person who is completely sedentary, who's doing nothing. If I can get them from very poor to below average, there's the greatest drop in mortality. It's not the person says to me, well, I'm going to do 50, 60 miles. I'm doing 40 or 50. The additional benefit to that is nil, very, very small. So many people don't realize that by vacating that bottom 20%, the least fit, if you're doing nothing, if you do something, there's the greatest drop in mortality, the biggest increase in survival. So that has, I think, motivational impact for a lot of people. You don't have to run. You don't have to do marathons. The point I make on a day-to-day basis, if you're doing nothing, do something. If you're doing something and you can do a little more, all those things make a difference. And we now know exercise and fitness are two of the strongest prognostic indicators relative to coronary disease, which I deal with. physically active people have up to 50% lower risk of heart attacks. And as I said already, each 1 MET increase in fitness, you decrease your mortality by 15 to 20%.
Right. So what I want to bring out in very plain layman's terms, what Dr. Franklin is saying, because we have listeners who we know are sedentary and in many cases feel hopeless and feel helpless and feel that because of their condition, whether it's lymphedema, lipedema, phlebolymphopolysaccharidemia, or garden variety, obesity, etc., where people have really become sedentary. The message I want to bring out through Dr. Franklin's knowledge and research is, do not think for a second that even 5 minutes of walking isn't helping you. It is helping you. It's not useless. It's not worthless. Don't give up on it. If you have to walk around the living room for 3 or 4 or 5 minutes, 4 or 5 times a day, what Dr. Franklin is telling us is that could save your life. That's what appears like a trivial amount of exercise, in your case, is really, really important. It's much more important than a person who's running 3 miles a day trying to get to 5 miles a day. Any activity that you can do is valuable and can save your life. Agreed?
Yeah, I'd agree with that. And I'd encourage those individuals to change their password on their computer to move more, sit less. So every time they turn on a computer, this gets to the success strategy. There's a subtle subliminal message: move more, sit less, better health.
Today's Lymphcast program is proudly sponsored by Vita Support MD, the makers of Vein Formula 1000 and Lymphatic Formula 1000. These MPFF-based nutraceuticals are backed by science and recommended by doctors specializing in venous and lymphatic disorders. Visit vitasupportmd.com to learn more.
Period.
Yeah.
To your point, one other thing, I oftentimes cite a study on patients with chronic kidney disease, and they look at those patients who are completely sedentary, and those who got up and just walked for 2 minutes every hour had about a 20% lower mortality. That's incredible when you look at small amounts throughout the day, 2 minutes of exercise per hour instead of sitting there. Or if you got it, rather than sending somebody an email, if they're right down the hallway, get up and walk over and talk to them.
Yeah,
those little things.
It's many years ago that I'm going to pass it over to some of our other panelists. Maybe Jacqueline has a question, but if I remember correctly, Dr. Franklin, many years ago in a lecture, you even talked about the health benefits of standing rather than sitting, that there may be some health benefits involved in that. Is that correct?
Yeah, that's exactly correct. Simply standing, it's called non-exercise thermogenesis. You increase energy expenditure by from 1 MET to about 1.5 METs. And what many people don't know is the slowest walking speed. Listen to this carefully. The slowest walking speed in almost any population, 0.5 mile an hour, very, very slow. You're burning 2 METs. So you could double your energy expenditure by getting up and moving at the slowest rate possible.
That's fantastic. Fantastic.
Oh, it's hard to get up and do anything without doubling your energy expenditure. Important information.
Fantastic. Jacqueline, any question from you?
Dr. Brittany. So when it comes to exercise, is it possible to get too much of a good thing?
Yeah, that's a topic that I've looked at and I'm very, very interested in. I actually put a couple notes on that. Couple things. First, I want to highlight to your listeners that unaccustomed, vigorous physical activity, particularly when performed by inactive, unfit people who may have underlying heart disease or structural cardiovascular abnormality, can acutely increase the risk of sudden cardiac death or acute myocardial infarction. So when people say, I want to start an exercise program, my answer is start walking very slow. Well, I used to run in track in the college and when I was 20. Well, you're not 20 anymore. You're now 60. And I guarantee over that 40 years, you've developed atherosclerotic cardiovascular disease. So start the program walking. The point I want to make is unaccustomed, vigorous physical activity can actually be potentially hazardous. Exercise is a double-edged sword. It protects against, but it can also, especially if you got hidden heart disease, pushing really hard one day, trigger acute myocardial infarctions. We see this all the time, by the way, in our community, where we get an older person who goes out and shovels heavy, wet snow and they haven't done anything for years. Those are people who can experience heart attack or sudden cardiac death. To your question, extreme endurance training regimens are associated with some, what I call cardiac maladaptations in some people. The literature would suggest in some people, they develop higher coronary artery calcium scores, which is a forerunner for cardiovascular disease. And in other people, they develop a heart rhythm irregularity called atrial fibrillation, which we see in a lot of older patients, which can lead to a TIA or, unfortunately, even a stroke. So the point I want to make is that recognize, in general, the more exercise you do, the lower your risk. But in some people, by really pushing double, triple the amount, the risk starts to go up again. It's called a reverse J-shaped curve. I guess the last point that I would make on this is this. 2 points. Endurance athletes, true, typically have higher levels of coronary calcium, which suggest underlying heart disease. But they also have higher levels of fitness, expressed as METs. Their blood vessels can dilate better than the average person. And if they have plaques in their arteries, they tend to be stable calcified plaques. So they're less likely to experience a cardiac event. So if somebody says, Dr. Franklin, I had a coronary calcium score, I have 200 a score, that's abnormal, isn't it? Yeah. Should I stop exercising? My answer is no, don't stop exercising. I want you to stay fit because fit people with any given level of coronary calcium have a lower mortality, better survival. Don't stop unless you start getting symptomatic. The other point is what's called atrial fibrillation. And lots of scientists have now shown that middle-aged and older people who really overdo it, high volume, high intensity exercise training regimens, are more likely to develop heart rhythm regularity called atrial fibrillation. What's the answer? Start walking, slow your intensity down, slow your volume down. And oftentimes those people who had developed atrial fibrillation go back into a normal sinus rhythm. So I think those are the major points, that exercise, too much exercise, you can get too much of a good thing, primarily elevated coronary calcium and the predisposition for the development of atrial fibrillation.
Fantastic. Paul Reeves, any question from you, from the quote unquote lay audience?
Yes, sir. Dr. Franklin, what about repetitive exercise? And by that, I mean the guy hasn't run at all, let's say in 10 years, decides he's going to run a mile a day. The first time he runs that mile, it's tough. Second day, it's a little easier. Maybe 3 weeks, it's really not too bad. But is there a point where that mile a day sort of taps out and it has a limited benefit because the body just gets used to, okay, mile a day, no big deal? Should he change up his routine?
Paul, I would tell everybody, number one, before you start jogging, I want you to start walking. Okay. The reason I say that is we have unequivocal evidence that many people in their 30s, 40s, and 50s have underlying heart disease. Studies at the Cleveland Clinic, studies in Sweden have recently showed if you're over 50, there's a 65% likelihood you already have clogged coronary arteries. So the point I'm making is exercise is good, but don't start jogging. I want you to start walking over time and gradually pick up your pace. Start walking at 2 miles an hour, gradually increase to 3, maybe increase to 4 over 2-3 months. If you do that, that's a safer approach to exercise than starting with more vigorous exercise. As an aside, I'll share with you, you'll find this fascinating. I was involved, and I wasn't sued, but I was involved as an expert witness in a recent case. This is relevant to our discussion. 38-year-old nurse, male nurse, BMI 37, 38, 37, out of shape, went to a club. I won't mention the club because he wanted to get in shape very, very quickly. They had him do what's called high intensity training. And day one, they had him jogging on a treadmill at 6 miles an hour, which is 10 METs. Paul, 6 miles an hour, 10 METs for a guy out of shape 40 represents, in my humble opinion, a maximal or supramaximal effort on day one.
Yeah. Right.
Had no business doing it. Long story short, he collapsed and died. They did an autopsy on this 38-year-old guy. What did he die from? Atherosclerotic, hypertensive, cardiovascular disease. And the kicker was his heart weight was 490 grams. For your information, a normal heart weight, and Dr. Chubeck is 300 grams, not 490 grams. So this guy had no business doing high-intensity training day one. So you want to start gradually, and then over time, gradually progress. If you have no symptoms, if you rate the exercise as fairly light to somewhat hard, that's a good estimate. And if you've had a stress test, they can tell you to some extent what your heart rate should be and what appropriate intensity would be. I don't know if that answers your question. I hope it does.
Mostly it does, but at some point, if the person just keeps doing the same thing over and over, I know you said to increase, but let's say the guy says, okay, I've been doing the walking thing, I've been doing the running thing. I don't think I can do much more than a mile. Is there a point where that 1 mile doesn't do as much good as it used to do? Should he try something else?
No, you're exactly right. He's working at a certain MET level, and if you continue to work at that MET level, you'll gain some benefit. But if you say I want maximal benefit, you got to work at a higher MET level. Okay. So if you came to our gym here, and you started walking at 2 miles an hour, hopefully after 2 or 3 months, I'd have you walking at 3 miles an hour up a 5, 6, 7% grade, where we go from 2 METs up to 7 METs, which would markedly increase your MET capacity, markedly increase the benefits of exercise for you. So it's the MET level that you're working at has to be gradually increased up to a point. And we'll talk about this later this evening.
All right. Thank you very much. Dr. Chubeck, I'll hand it back to you.
The other thing I would like to highlight, which I thought was one of the most fascinating things in listening to Dr. Franklin talk in years past, were 2 of the really great risk factors for having an acute cardiac event for people who had been sedentary or not exercising at a high level. One, as I recall, Barry, was getting involved again in middle age and so forth in racket sports. And the other one was, as you mentioned, shoveling snow. Now, most of our panelists have been smart enough to move to places where there is no snow anymore.
I'm talking about me.
Yeah, I'm talking about you. She used to be in Rochester, Minnesota. Now she's in Phoenix, Arizona. But Dr. Eicher is in Santa Monica. Paul is in South Florida. Jackie and I are still here in the Northeast in New Jersey. But one of the things I want you to share, again, a little bit more specifically, because I know you're very familiar with that data, the studies you did at Beaumont in terms of the amount of work that actually gets done in shoveling a driveway. Okay. You wouldn't think it was a heck of a lot of work, but I remember you throwing some numbers out that really blew my mind.
Ben, your question's an excellent one. And the fact of the matter is, every year, middle-aged and older people get heart attacks or die from shoveling heavy, wet snow. We did a study here in the early 90s. We published it in a decent journal called JAMA. And JAMA looked at it, and it was only 10 healthy men. What I went to is the Human Investigation Committee. I said, I want to study 60, 70-year-olds with shoveling snow because there are heart attacks every year. I want to study those guys at Beaumont. And the Human Investigation Committee gathered, and then they came back and they said, Dr. Franklin, we like your idea. We want to make one minor change. We want you to use healthy guys 30 years of age or younger and have them shovel heavy, wet snow and extrapolate the data on older individuals. Snow shoveling requires several things that disproportionately increase the demands on the heart. Arm work, more taxing than leg work. Valsalva, straining to lift heavy workloads, can cause abrupt changes in heart rate and blood pressure. Cold temperatures Cold temperatures increase vascular resistance. In other words, arterioles go from here to here because of those cold temperatures, increases blood pressure. The other point that I would make is that when you're shoveling, you're largely standing still. If you're walking on a treadmill, you're promoting venous return. When you're shoveling, blood tends to pool in the lower extremities. Heart's beating very fast, and it's not coming back to the heart, to the head. So as George Clooney would say, it's a perfect storm. All these things happen, and as a result, heart attacks occur every year. To your point, how heavy is the load? We measured a shovelful of heavy wet snow with 16 pounds. We had young guys shovel snow for 10 minutes. They did 12 shovels a minute times 10 minutes. Do the math. 16 times 10 times 12 is almost 2,000 pounds in 10 minutes. Maybe for a 20-year-old, but about 50, 60-year-old, it's like moving a mid-sized car, John. So and last but not least, we took these guys, we did a stress test on them, maximal stress test, maximal heart rate, maximal blood pressure. And on a different day, same time of day, we had them shovel heavy wet snow in the back parking lot of Beaumont. What's amazing is these guys got to heart rates and blood pressures that were higher than during their maximal treadmill test. You couple that with the cold temperatures, you got a perfect storm. So for all those reasons, it's one of the few activities I tell older people with known or suspected heart disease, you shouldn't be doing shoveling heavy wet snow. One of our fellows, who's now my cardiologist, did a research study here, and he showed that over 2 major snowfalls in the Detroit area, we had 36 people who dropped dead while shoveling or using an electric snow thrower after 2 heavy snowfalls. So it's a dangerous activity, to say the least.
So amazing stuff. As winter is sort of closing in on us, everybody, please take that warning very seriously. And before engaging in that activity this season, please see your doctor, see your cardiologist, and make sure that you're cleared for that kind of activity. It can be taken very lightly, but it's literally a heavy subject. You're talking about 1 ton of snow being moved. It's a lot of work, and it doesn't necessarily appear to be. And that always stuck out in my mind. Monica, anything from you?
Yeah, I had another question concerning the cholesterol. What is that rule of 40 for cholesterol? Could you explain it?
That's a great question. The rule of 40. I remember being a young guy in my career, and I was sitting next to an idol, and John may be well aware of this name, Dr. William C. Roberts, who was the editor of the American Journal of Cardiology, Baylor Medical Proceedings, and I'm sitting next to this giant, and we're chatting, and I got to know him. And I remember vividly sitting on a plane, and he's a big advocate of preventive cardiology, and I said, Dr. Roberts, give me a pearl from all the pearls you have. You're the one of the key people who said cholesterol is bad for you. Cholesterol is intimately involved in the atherosclerotic process. What do you want me to know as a young student? And he looked at me with that Baylor drawl, and he said, Bear, remember the rule of 40. And I said, what's that, Dr. Roberts? And he said, Barry, for every 40 points you lower the cholesterol, you're going to cut the risk of a cardiac event, a heart attack, in half. So I said, give me an example. And he said, well, you got a cholesterol of 240, and you take that down to 280, and you take that down to 240. Barry, you cut your risk of a heart attack in half. Take it from 240 down to 200, you cut your risk in half again. And take it from 200 down to 160, which is a lot of our patients because they're taking statins, you've cut your risk in half again. So Roberts taught me the rule of 40, and he also said if you're taking statins, in general, whatever the statin is, if you double the dosage, you get an additional 7, 8, 9% drop in total and LDL cholesterol. So if you're trying to get a certain value, for example, I tell patients with at risk, I want to see your cholesterol under 150. I want to see your HDL, the good or helpful form of cholesterol, over 40, and ideally over 60. And I want to see your LDL cholesterol certainly less than 100, and the latest research suggests less than 70. For many people, that's going to require not only diet and exercise, it's going to require complementary or adjunctive statin therapy. In my opinion, the two best statins, this is not a commercial. I don't work for the pharmaceuticals, but I take Crestor myself and another, which is rosuvastatin or atorvastatin and Lipitor, have been shown to be the most powerful statins reducing mortality, particularly in people who have known heart disease. So I strongly recommend those. Rule of 40, for every 40 points you lower your cholesterol, you cut your risk of a heart attack in half. Pretty profound.
And I have another question concerning the cholesterol. Some patients are having trouble not only to decrease the LDL wrong cholesterol, but to increase the HDL. Any tips how to help those patients?
Yeah, your question is a good one. And the statins don't do very much. You're correct to increase the HDL cholesterol, the protective cholesterol. I have found some adjunctive things. Omega-3 fatty acids, fish oil, may slightly improve it. I have found that taking niacin, personally, my HDL at one time was in the 30s. It's now in the 50s. I exercise a lot. I eat healthy, but I also take niacin twice a day. And people say, well, I don't like the flushing. I take it before bed. So if I'm flushed at 3 o'clock in the morning, I'm not worried about it. Those things, and there's good evidence that exercise raises HDL cholesterol, but in my opinion, an honest opinion, that's overrated. You got to start running marathons to really raise your HDL cholesterol with exercise. So I'd say basically omega-3s, weight loss may be helpful to you, and niacin does raise the HDL cholesterol. Your question's a good one.
Wonderful. Well, I think that we have roughly about 15 minutes left in our program, and I do want to switch gears. I know Dr. Franklin has prepared some slides for us, and I'm going to share those now.
Okay.
While you are preparing that, I have another question. We don't have a snow in Santa Monica, but we have a Venice Beach. And there are so many people with the heavy weights showing off and lifting heavy weights. What is it comparable to the snow, shoveling the snow, or should they start very slowly with the heavy weights or low weights? What would you recommend, Dr. Franklin?
Yeah, most of the men who are doing heavy weights have been doing heavy weights for years and years. They do it for bodybuilding, they do it for appearance, and so on and so forth. The fact of the matter is those people really aren't any healthier, or maybe less healthy than the average individual. So I tell patients weight training, resistance training is good, but the focus ideally should be on aerobic exercise, walking, bicycling, climbing, and so on and so forth, and use resistance training as a complement too. We've also done studies on some of these resistance heavy bodybuilders, and their risk factor profiles are horrendous. Part of that there may be a confounder. Some of those guys are taking steroids, which can have adverse effects on a whole host of body functions. So your question is a good one. Right. It's not something I routinely heavy weights recommend, although many 20 and 30-year-olds and 40-year-olds are into that. It doesn't necessarily guarantee health, and some studies suggest via biochemical analysis and so on and so forth, their health may be compromised by that heavy weightlifting alone. Question's a good one. These are some slides I put together over the weekend to try to summarize or take-home messages from the discussion that we've had. And if we could advance this slide, I'll share those in closing this Lymphcast. Once again, we talked about METs. I guess I'd make 4 points here. Once again, METs are the amount of oxygen your body uses at rest. The average adult, if I take the average 40 to 60-year-old, 30 to 60-year-old, has an exercise capacity of 6 to 12 METs, which means they can increase their energy expenditure 6 to 12 times. heart failure patients, many morbidly obese, are only 2 to 5 METs. And we have a cardiovascular performance clinic here where we sometimes bring in elite athletes. That's me standing there in the background taking a blood pressure, where we get up to 20 to 25 METs. People should recognize even a small increase in fitness, 1 MET, transforms to about a 15 to 20% reduction in mortality. So that compares very favorably with aspirin, statins, beta blockers. And the last point I'd make is, regardless of what your risk factor profile is or your coronary calcium score, low fit men and women have about twice the mortality as their high fit counterparts. So if anything, on anybody, we want to try to get them out of the least fit cohort, which means you got to have an exercise capacity, ideally around 4 to 5 METs, which means you need to exercise at 2 to 3 METs. I contend that the vast majority of your patients can ultimately exercise 2 to 3 METs. Next slide.
Fantastic. Barry, can you hear me?
Yes.
If you're going to cover this, then just go ahead. But I'm going to interrupt just to ask, because it's another great thing that I remember learning from you years ago. Mm-hmm. Because of our patients who have, in many cases, lymphedema, lipedema, who may have increased body weight, may fall in an obese or even super obese category with increased BMIs, etc. Is it possible to be overweight and still fit or be at decreased cardiac risk through exercise?
The late Stephen Blair. Steve Blair was a giant in the field, recently passed away. The late Stephen Blair really kind of pioneered that topic. And what I would say is, first of all, there's not too many obese people truly who are highly fit. That said, what we do have data to suggest, whether you're normal weight, overweight, or obese, if your fitness is considered average to above average, you have better health, better prognosis. So that's, I think, more realistic to frame it from that context.
Excellent. Thank you so much. Here's your next slide.
Yeah. When people ask me how much exercise should I do, I typically go to the World Health Organization guidelines. They advise exercising at least 150 to 300 minutes per week, or vigorous activity of 75 to 150 minutes per week, or combinations thereof. I find that these often discourage the hell out of people because they say, well, how can I do 150 minutes? First of all, that's 30 minutes 5 days a week. Let's take the minimum amount. Others have shown that health benefits can be achieved at levels even below this. So, John, it gets to the point we made earlier. If you're doing nothing, do something. If you're doing something, do more. Small amounts of exercise accumulated throughout the day can have a profound and favorable impact. If it can improve the fitness overall, we should be able to achieve normal lifespans in the vast majority. I see heart failure patients who have higher fitness levels and who are living in the 60s and 70s. And typically that would have never happened. So I believe fitness is very, very important, and we need to find a way to make it accessible, enjoyable, and doable. And if it's a matter of taking it into 3-4 minute bouts of exercise throughout the day, so be it. From a typical standpoint, this gets back to a point I made earlier. We want to try to get people, if possible, it's not always possible, over a 5 MET exercise capacity. That means when you put them on a treadmill, they reach 5 METs. For your information, that's stage 1 of the Bruce treadmill protocol, 1.7 miles an hour, 10% grade. Some of our patients can't do that. Some of your patients, I'm sure, can't do that. The ultimate goal, though, is not training 5 METs. It's getting them to exercise at 3 METs or higher. And the magical workloads, which may take a long time to achieve, is 3 miles an hour. Flat grade is 3.3 METs. Many of my heart failure patients can do that. Many of our obese patients can do that. Or if people say to me, Franklin, 3 miles an hour is just too fast for me, I said, fine, take it down to 2 miles an hour. Start on the level at 2 miles an hour. Every 2-3 weeks, add 0.5%. You're not even going to know the difference if we added 0.5%. And after 6 months, you're going to be working at 2 miles an hour, 3.5% grade. You're going to be exercising at 3.3, 3.4 METs. You're going to have over a 5 MET capacity. And as we said early on, you get a 5 MET capacity, that's the biggest bang for your buck, John, to the point you made earlier. It's not running 50, 60, 70 miles. Yes, you get a little more, but the biggest bang for your buck is getting a 5 MET capacity with the goal to ultimately get up to 3 METs. Many patients can do that. Next slide. And stop me if you have questions. I'm not sure what happened here. Let's go to the next slide.
Oh, let me try to go back. No, I don't know why that's not functioning.
Okay, well, I can tell you what that showed. Let's go back because I remember what that showed. Basically, what that showed is this. In general, if you can work at a higher MET level based on age and gender, that higher MET level will guarantee increased survival, decreased mortality. And I gave a specific example of a 52-year-old woman. And if that 52-year-old woman can exercise 4 METs or higher, it may take her a long time, she's going to have good fitness and the optimum benefit from exercise. Next slide. We didn't get into eating, and that was one of the questions, but I know we had a lot of stuff. But when people say to me, does a healthy diet really make you live longer? The answer is yes. I study people who live in certain areas of the world. Those areas are called blue zones. These are people who routinely live to be 85, 95, 100, 105. Sardinians, Adventists, Okinawans. If we look at the center of that slide, these are common characteristics of people in all 3 areas of the world who live long. Number one, they don't smoke. We didn't get into smoking, but smoking reduces the lifespan on average by 10 to 12 years. It's not weeks or months, that's years. So when people say to me, what should I do? First thing, if you can stop your cigarette smoking, you're going to gain overall 10 to 12 years. Number two, interestingly enough, my wife's been telling me this for years, put family first. People who put family first live the longest. Be physically active every day. Walk, move more, sit less, keep socially engaged. And the point I'm making here is the bottom one. Eat lots of fruits, veggies, and whole grains. I tell patients, eat whole grain bread. I tell them the whiter the bread, the sooner you're dead. So stay away from white bread. Eat 6-7 servings of fruits and veggies every day. And lastly, John, a blockbuster study, JAMA Internal Medicine, Harvard researchers showed that people who adhered to healthy dietary habits had a 20 to 25% lower mortality in a 36-year follow-up study in a recent JAMA article. So to get to your question, we talked about this. Yes, healthy diet makes a difference.
At VitaSupport MD, we believe in creating the best bioflavonoid-based supplements to support your vitality. Bioflavonoids are found in abundance in nature and support excellent health and wellness. The demands and stresses being put on our bodies in these challenging times are unlike any we have seen before. Support your body with the flavonoids it needs to fight inflammation. And at VitaSupport MD, we believe in creating the best bioflavonoid-based supplements to support your vitality. Bioflavonoids are found in abundance in nature and support excellent health and wellness. The demands and stresses being put on our bodies in these challenging times are unlike any we have seen before. Support your body with the flavonoids it needs to fight inflammation and oxidation. Unlike other products in the marketplace, VitaSupport MD dietary supplements use micronized flavonoids for optimal absorption and effectiveness. Micronization is an advanced process which creates an ultra-fine powder easily absorbed by the body. At VitaSupport MD, we are passionate about making your good health our life's work.
Next slide. We were talking about risk factors. Only thing I want to point out here, and if you can advance it once, just to highlight, see if that'll work. Can we advance? Excellent. That works. The only point I want to make here is that when people say, Dr. Franklin, what risk factors do you focus on? I focus on LDL cholesterol. I focus on diabetes, hypertension, cigarette smoking, obesity, physical inactivity, and low aerobic capacity. So we keep getting back to low physical inactivity, low aerobic capacity. American Heart Association says are major risk factors. Anything you can do to combat those individually or collectively lead to what we call endothelial function, which means they screw up the inner lining of the blood vessel, make it more susceptible to take in cholesterol, calcium, and so on and so forth, and lead to big problems. The fact of the matter is, risk factors account for 75 to 90% of all acute coronary events, and patients should do what they can to combat those risk factors. Next slide.
Does it mean that in fact cardiac acute events are at least in 75% preventable?
I would agree with that. Not 100%, but I'd agree that 75% preventable. Yes, 75 to 90%. Then you might say to me, Barry, what about the other 10 to 25%? I believe some of that 10 to 25% is probably due to pollution, probably due to psychological stress or anxiety or depression, and probably due to related psychologic factors, which we haven't even talked about today, but do play a role in the development of cardiovascular disease. This slide, I think, reiterates a point I tried to make earlier, and that is, can we estimate the METs from walking speed? We can. At a 2 mile per hour walk, each 3.5% increase adds a MET. So if you're walking on a treadmill at 2 miles an hour, 0% grade, you're at 2 METs. At 3.5%, you're working a little over 3 METs. At 3 miles an hour, you're working at 3 METs. For each 2.5% increase in treadmill grade, you add a MET. So if I have a patient who says to me, Dr. Franklin, I don't want to work at 3 miles an hour, but I want to be working at 5 METs. What do I need to do? 3 miles an hour is 3 METs. 3 miles an hour, 2.5% grade is 4 METs. 3.5 miles an hour, 5% grade is 5 METs. So we can estimate these things fairly accurately. Next slide.
And the other thing that I would
stop me anytime.
Sure. I would just add that many of the newer treadmills will show you the METs.
You're exactly right. And those are pretty darn accurate, John. They're really pretty accurate. One other little caveat I'll share with you guys. We can also estimate METs fairly accurately from a heart rate equation. This is not calculus or algebra. It's 6 times the heart rate index minus 5. 6 times the heart rate index. So you say, Barry, what's the heart rate index? John, I had a patient the other day who said, Dr. Franklin, I work at, my resting heart rate's 60 and my maximal heart rate when I exercise is 90. Can you tell me how many METs I'm working at? The heart rate index is the exercise heart rate divided by the resting heart rate. So 90 divided by 60 is 1.5. 1.5 times 6 is 9. Minus 5 is 4 METs. I tell that patient, you're probably working at around 4 METs. Does that make sense? 6 times the exercise heart rate divided by the resting heart rate minus 5. You could estimate the METs fairly accurately.
And what if patients is under the beta blocker therapy with the?
Your question is a beautiful one. This formula was developed by a friend in Australia, John Wicks, who used patients with and without heart disease on and off beta blockers, and the formula still was accurate for predicting METs. 6 times the exercise heart rate divided by the resting heart rate, then minus 5 from that, you could come up with a fairly accurate estimate. So even with patients on or off beta blockers, that formula works. We use it clinically a lot. Advance, please. Can we move it forward? This is a paper we published in Circulation. Oh, great. We published in Circulation. I was the lead author in 2020. It gets to one of the questions, can you do too much exercise? Is it possible to get too much of a good thing? We made 2 major points in this 30-page paper. Unaccustomed physical activity, particularly when performed by inactive, unfit, susceptible people, that is, people who have unknown heart disease, can actually increase the risk of sudden death and acute myocardial infarction. That's the reason why I said start walking. Don't start running day one. even if you did it 30 years earlier. And secondly, extreme exercise regimens may in fact increase the level of coronary calcium and the risk of incident atrial fibrillation. Nevertheless, the higher fitness, the greater vasodilatory capacity, those are factors that discount the increased coronary calcium. So those people generally do better, even with a higher level of coronary calcium, to get rid of the risk of atrial fibrillation, cut down the exercise. It's the high volume, the high intensity exercise. One study showed when you got 2,000 hours of high volume, high intensity exercise, the risk of incident atrial fibrillation goes up markedly. That's a lot of exercise over time. Next slide.
Yeah, I would just throw in there that as a cardiac surgeon, it always seemed extreme to me when you consider the heart as a pump and it's a physical mechanism, that people who are getting into exercise regimens like super marathons of 100 miles of running and so forth, it just, from a purely logical and gut instinct point of view, seems that it would be counterproductive and too much work for the heart.
I'm in total agreement with what you just said, and that really exemplifies what's known as the reverse J-shaped curve. In other words, more exercise, lower risk, more exercise, lower risk, and then finally the risk starts going up again with these extreme regimens. This is a cardiovascular performance clinic we developed at Beaumont. For your information, we had 3 deaths in the Free Press Marathon 2009. I said to the hospital, we got to do something about that. We got to open up a cardiovascular performance clinic. I called a friend at a hospital you may have heard of called Mass General, and he's with Harvard. Aaron Bagish is a cardiologist. They've been doing this for years. We started doing it, and it's been a huge success. We do a stress test, echocardiogram consults. We charge $370. We're not making any money on it, but it's brought a lot of people in, and we've alerted a lot of runners that you shouldn't be doing this high-intensity exercise until you get evaluated by a cardiologist. Next slide.
Barry, I'm going to stop you there. It's an excellent point and something I meant to ask earlier. For our patients listening, we have patients of all kinds, but especially our patients, lymphedema, lipedema, etc. But in general, quite frankly, who should see their doctor before starting an exercise regimen of any kind? And should it be a primary care physician like an internist, family practitioner, general practitioner, or should they see a cardiologist?
I'll tell you something you'll find surprising, but this is fact. The U.S. Preventive Health Services says the use of seeing a doctor or doing a max stress test before starting an exercise program is controversial. And they go so far as to say, if you're going to start a walking program and you're symptom-free, you don't have to have a stress test. You don't have to see your doctor. If you want to start a more vigorous program, then they say, yes, it may be advisable, especially for people at higher risk. For example, the diabetic or the person who has some vague chest pain, which may be an anginal equivalent. But I think the prevailing theory is it's more risky not to do exercise than to do moderate intensity exercise. And you don't need all kinds of medical evaluations to go out and start a walking program at 2 and 3 miles an hour. I don't recommend people start jogging or running or spinning classes unless they've been evaluated by a physician, internal medicine, or they may recommend them to a cardiologist. And then a stress test, if they really want to push right away, may be helpful in identifying myocardial ischemia, arrhythmias, symptoms, and so on and so forth, which would preclude that vigorous exercise until they were further studied. Coronary calcium score, CTA, or even cardiac catheterization.
Fantastic.
This slide, there was another, I'm not sure why the top one didn't show up, but when we do a stress test, we're basically looking for 2 things. If you look
sinus tachycardia.
Huh?
Sinus tachycardia.
Well, this one is
ST depression.
Yes, that's what I'm highlighting. This is ST depression, and I had a picture of ventricular tachycardia. Two of the key things we look for is this ST depression, this slight depression. And by the way, this was in a marathon runner who just finished a marathon, John, and he told his doctor he had some chest pain. The doctor said, "You just finished a marathon. I'm sure you're fine." They went ahead and did a stress test. He had some chest pain. You can see some ST segment changes here. They went in and did a cardiac cath. He had a 95% LAD lesion. This was published in JAMA a few years ago. So the point I'm making is stress testing can be helpful in identifying silent ischemia or malignant cardiac arrhythmias. That's the only reason I showed this.
Many years ago, I did a 6-vessel bypass on a 38-year-old executive from Sony who was a marathon runner who had just very vague anginal equivalents, and his cardiologist, being very astute, insisted on a cardiac catheterization, and he winded up getting 6 grafts.
Wow, unbelievable. Well, once again, exercise is good, but it doesn't guarantee immunity to coronary artery disease. My good friend Tim Noakes in South Africa in the 70s published 6 cases of marathon runners with known cardiovascular disease. So in general, it reduces the risk, it increases longevity, but it does not guarantee immunity to coronary disease, which is what you're highlighting from that particular case.
Agreed.
Patients with lipedema at increased risk for cardiovascular disease. I've reviewed the studies. You guys may dispute me, but most studies suggest that there's not a direct link between lipedema and cardiovascular disease or diabetes. That said, I'm troubled by the fact that many of these patients, if you go to the next slide, which a slide that I oftentimes show, and advance once more, obesity is a central risk factor for cardiovascular disease. Once more, please, just one advance if we can show that. I don't know. There we go. There's a lot of things associated with obesity. So although I didn't find a study that said lipedema causes cardiovascular disease, it's associated with obesity, which could be related to thrombosis, hypertension, increased triglycerides, decreased HDL, increased LDL, indices of inflammation, metabolic syndrome. So for all these reasons, I think it's important to address these risk factors in people who may have these risk factors to the best of our ability with lifestyle change and pharmacotherapies if appropriate.
There is one article written by Szolnoki from Hungary where he studied lipedema patients and he found aortic stiffness in these patients.
Okay. Now, did he classify these individuals according to body habitus? I'd imagine most
No, they were strictly lipedema patients.
Okay.
Yes.
And increased arterial stiffness.
Yes.
Okay. These are the general benefits of moderate to vigorous exercise in patients, and this applies to patients with lipedema. There are psychological benefits. I think these would be very, very important in your patient population who often experiences depression, life strain, and so on and so forth. But we also have evidence that there are antiarrhythmic, antithrombotic, antiatherosclerotic, and anti-ischemic effects. So in addition to improving cardiorespiratory fitness, there's a constellation of effects that can be achieved just with moderate exercise. And these are some of the most common benefits of exercise.
Great slide. Mm-hmm. Oh, here's another great slide.
Yeah, I guess if we can advance this slide, I guess the last point that I'd want to leave you with is this. And Dr. Chubek is well aware of this because we publish on the same things and our hobby is the same. There's an overwhelming body of evidence in the self-help literature that you become what you think about. So I tell our cardiac patients, which also pertains to your patients, write down and visualize your health and appearance goals and think about them often. It's the best advice I could give you. A very famous self-help guy by the name of Claude Bristol said, it's the tap, tap, tap. Constantly think about your goals. Constantly see yourself as you want to become. Critically important. By the way, good times to think about this is before going to sleep or immediately upon awakening. I've gotten in the habit, and it works, of thinking only positive things. I'm going to do this podcast today and it's going to go off beautifully. I'm going to finish this and it's going to be done. Talk about things that you expect to get done. Another thing that I emphasize to patients, embrace what I call HOG. What is HOG? Happiness, optimism, and gratitude. Patients who embrace and radiate happiness, optimism, and gratitude attract more things to be happy, grateful, and optimistic for. Recognize, as I say here, the subconscious mind is a powerful magnet for bringing the goals and desires that we have. As I mentioned, I oftentimes think about something that's important to me, and my computer says it's time to change your password. I changed it the other day to take action, number one. In fact, taking action, number one, is one of the secrets of success. In a nutshell, I'll leave you with three things that are highlighted in this book and the excellent books that Dr. Chubik has written. If I'd summarize all this in three words, my philosophy is believe, act, achieve. Think about your goals, take action to achieve them, and you go from there. I love a car bumper sticker that I once saw that said, "You are your own fortune cookie." I also love this quote by Henley that's in my book, but it's in all the success books. "I am the master of my fate. I am the captain of my soul." And lastly, another quote that I love that's actually in my office. I don't know if you guys can see this. This was given to me by a staff member because I always say it. If it is to be, it is up to me. To me, those are the kinds of things that move us ahead in health, in success strategies, and in life. So that basically summarizes my presentation. Thank you guys for the opportunity. Thank you, Dr. Chubik, for the opportunity.
Oh, thank you, Barry. This has been really a very, very special episode, a wonderful episode in so many ways. And I couldn't agree with you more in your final statements about the power of the subconscious mind, which begins with the thinking mind. And we become what we think about most of the time. And so if we can think about good health and we can think about happiness and success and achievement and weight loss and increasing our exercise and increasing our physical activity and really do that on a regular basis, almost as a meditative or mantra kind of process, over time, those thoughts that exist in our conscious mind will penetrate what I like to describe as the psychic barrier and find their way into the fertile soil of our subconscious mind. And in the subconscious mind, those seeds of greatness will grow within us and affect our habitual behaviors, which eventually will determine our results.
Total agreement. We're on the same page.
Dr. Franklin and I are planning to do some programs together, some seminars and so forth, on the work that we've done on personal development, personal growth, achievement, and the mind. And I look forward to those future events, Barry, that we're working on. Well, any final thoughts from any of our committee members, our panel members, before Paul signs us out?
Well, I think that this is all extremely inspiring, and right now the only thing I would like is to go and exercise.
I agree.
I appreciate your kind words, but it works. There's no question about it. You don't have to run marathons. Just get out and walk, move more, sit less, get the circulation going. We published a paper in Lancet last year that showed physically active people are far less likely to experience dementia as they get older. So that's another reason.
I believe it, truly.
Thank you. Been a pleasure working with this entire team. John, I oftentimes say I try to surround myself with people who have skills, abilities I don't have. That's my secret. I guess that secret is out.
Yeah, we're all trying to do that, surround ourselves with fantastic people.
Yeah.
And it has been a real pleasure to see you again and work with you again. You're an inspiration, as Dr. Glevitsky said. And yeah, I think we all would like to go for a nice long walk and eat a big salad with some grilled fish or grilled chicken or something like that. It'll be a while.
Vinaigrette dressing, yeah.
Exactly. Stay out of the drive-through window.
Thank you, guys.
Paul, I'm going to pass it back to you to say goodnight.
All right. We appreciate everybody for listening and or watching tonight, the Lymphcast episode number 35. Check out our website, lymphcastnetwork.com. You can find everything on YouTube and also every podcast platform under the sun, Apple Podcasts, TuneIn, Stitcher, Spotify, Google, Amazon, Audible. We're all over the place. So check us out, and we are appreciative that you do. Let's go ahead and thank our panel before we sign off. From Arizona, Dr. Monica Glavitsky. Thank you, Dr. Glavitsky, for everything tonight.
Thank you, Tim, and thank you, Dr. Franklin. I have just last thing. If I send through John your book for your signature, would you be so kind as an author to put some words for me?
Of course. I'd be more than happy to. Of course. Yeah.
Thank you.
Thank you. Sure.
All right. Very good. Also from California, Dr. Emily Eicher. Thank you, Dr. Eicher, for everything today.
Thank you, Dr. Franklin and the team. And if I kindly request the same as Dr. Monica.
Okay.
And one question, as a former gymnast, what was your event?
I worked the still rings at Kent State University. I worked primarily the still rings, and I must share with this group, my goals as an undergraduate was which new trick I was going to learn on the still rings and which attractive lady I was going to take out over the weekend. That was my goals. And I became a senior, and I realized those aren't going to pay the bills or lead to a meaningful career. And I ended up getting into University of Michigan, and people said, how'd you do it? I had an interview with somebody, and he said, we don't take people with a C+ acumen. I said, if you let me into Michigan, I won't disappoint you. I got into Michigan because of that face-to-face interview. So I tell people all the time, young people, get a face-to-face. Don't just send an email because you'll never get in.
Yeah. Very, very good advice for sure. From New York, RVT, Jacqueline Sassick. Thank you, Jacqueline, for everything.
Well, and thank you, Dr. Franklin. I guess we're 3 for 3 in requests of some signatures on your books. So thank you. It was a pleasure.
Thanks, Jacqueline.
Why don't we just ship him 100 books? He can sign them all, and we'll have many for each person.
My pleasure.
Dr. Chubak, you bet. Dr. Chubak, before we sign off, can you go ahead and officially thank Dr. Franklin for all of his help tonight?
I would be happy to do so, but before that, I have to show off a little bit. I don't want anybody to be jealous. You can't read what mine says. It's very personal. Mine is already signed. Anyhow, Barry, Dr. Franklin, thank you so much for your time with us today, your inspiration, your incredible leadership, not only in this program, but in looking back at what has been and continues to be a remarkable career in clinical medicine. And as a PhD, you've done something which is quite remarkable in a world driven in many ways by MDs, but you have made a mark and a contribution far beyond what most medical doctors will ever make in the clinical realm through your work in the clinic every day, treating patients, taking care of patients, and your work in terms of science, research, and writing. And I want to just say for the record, when I look at your 700 publications, I'm only 695 behind, but I'm coming, Barry. I am coming.
Let me add one other thing. You were very generous. In my book, I say the foundation of highly successful people, and I'm sure I can tell everybody on this call, love what you do, serve others, take 100% responsibility for your life. If it is to be, it is up to me. You address those 3 things, you're going to be eminently successful, whether you're a PhD or whether you're a renowned cardiovascular surgeon or vascular surgeon. So those are the keys.
Amen. Thank you so much. It's a pleasure to have you, and we hope to spend time together again in the very near future.
Sounds great. Thanks again to all of you. Pleasure working with you.
Thank you, Dr. Franklin, and the founder and owner of this show, the Lymphcast Show. He's also the founder and owner of Vital Support MD, our sponsor. They make Vein Formula 1000, Lymphatic Formula 1000. From New Jersey, physician, surgeon, Dr. John A. Chubak. Thank you, Dr. Chubak, for everything.
Thank you, Paul. Good night, everybody. We enjoyed it. It was a great program.
Thank you.
Thank you. And again, you've been watching and or listening to Lymphcast episode 35. Have a great day. Thank you.
Thank you.